Hi, hello friends, welcome back to channel. So today we'll be doing something interesting, like we'll be taking a congenital heart disease case where we'll be discussing the examination part of the cardiovascular system in detail. I'll be showing you the demonstration videos along with the explanation for each of the clinical finding that we have found in this congenital heart disease patient. And also initially we will have a quick wrap up of what all the congenital heart disease possible, cyanotic heart diseases, and why do these happen. The pathogenesis also we will have a quick go through, then we will go into the case. First, with respect to normal heart development, there will be two heart tubes which will come and they start fusing together in the center. So what happens is the two ends in the downward portions will become the primitive atria, and this fused portion will become the primitive ventricle, and the upper end of this tubes will become the truncus arteriosus. Truncus arteriosus means it gives origin to two trunks. One is the pulmonary trunk and one is the aorta. Okay, yes. So then what happens if you see, there will be a septum growing. Okay, from below upward, a septum which is a ventricular septum which will be dividing the right and the left ventricle, as well as a aortopulmonary septum from growing from above downwards, which will be dividing the pulmonary and aortic trunk. But actually if you see, the pulmonary trunk will be in the left side and the aortic trunk will be in the right side when the heart develops. So actually what should happen? A pulmonary trunk should fuse with the right ventricle and aorta should fuse with the left ventricle. So that means this septum should spiral, should undergo spiraling. So only the right ventricle eject into the pulmonary trunk and left ventricle will eject its blood into the aorta. So this is the most important step, which is the spiraling of the septum, aortopulmonary septum. Okay, so aortopulmonary septum, initial part of development. Next, spiraling happened. Next, what should happen is this interventricular septum should develop properly. The muscular part will be developed properly, but the upper end will be contributed from the endocardial cushions. Endocardial cushions means which forms the valves that will contribute some to the development of this interventricular septum. And also your aortopulmonary septum also will contribute a minimal to the development of interventricular septum, as well as the muscular part of the interventricular septum also grows to some extent and forms this membranous septum. Okay, yes, this is the basic steps, 6 steps in the development of the heart. So now what all happened? First, if you see, two heart tubes came, fused together, primitive atrium, primitive ventricle, truncus arteriosus. Two septums formed, interventricular septum, aortopulmonary septum, and the aortopulmonary septum spiraled to connect the right into the pulmonary trunk, left ventricle into the aorta. Then what happened? Development of interventricular septum. What all contributions it got. Yeah. Now let's see the abnormalities which will happen if this process of development is not happened properly. First is the aortopulmonary septum which doesn't develop at all. There will be no segregation of pulmonary trunk with the aorta. So it will be a common chamber ejection outflow tract will be there for both the right ventricle and left ventricle, manifesting as cyanosis at birth. And it's not at all possible for the baby to survive for long if not corrected urgently. Next, this is persistent truncus arteriosus. Next, if you see the spiraling of the septum, which I told, if it doesn't happen, what will happen? Left ventricle will be ejecting into the pulmonary trunk and right ventricle will be ejecting into the widespread systemic circulation. It's never possible for the baby to survive if it doesn't have an associated shunt like an ASD or VSD must be there for the baby to survive. Next, what if the aortopulmonary septum is shifted rightward, upward and anteriorly? If this happens, what will happen? If it shifts rightward, then what will happen? The pulmonary trunk will be shifted to right, and the aorta will be a common chamber for the left ventricle as well as the right ventricle, which we call it as overriding of aorta. Next, since it is shifted rightward, and this pulmonary trunk will be narrowed. Okay, so there exists a component of pulmonary stenosis. Next, if you see, due to pulmonary stenosis, the right ventricle ejecting blood into the aorta as well as into the pulmonary trunk gets hypertrophied consequentially. There will be a right ventricular hypertrophy. Since the septum, as I told, it's shifted superiorly, so there is a gap between the two ventricles. So there also exists a ventricular septal defect. Thus, the tetrad of a VSD, RVH, PS and overriding of aorta will contribute your tetralogy of Fallot. This tetralogy of Fallot patient we are going to discuss now clinically. So here, if you see in this patient, the patient is having distal bulbous enlargement of the fingers. Okay, this is clubbing as well as bluish discoloration of the fingers as well as toes. There's a pan-digital clubbing of both the hands and both the feet, as well as cyanosis is present. As well as if you see, the conjunctival mucosa appears too much reddish, and also the tongue, the mucosa below the tongue also appears excessive reddish erythematous, as well as erythematous mucosa is seen in the conjunctival palpebral conjunctiva also. So this means the patient is having a triad of clubbing, cyanosis, polycythemia. These three happen in any congenital cyanotic heart disease. Actually, in any cyanotic heart disease, if you see, since the deoxygenated blood is mixed into the systemic circulation, there will be a degree of hypoxia. So this hypoxia will be stimulating your kidneys to produce lots of erythropoietin and lots of RBC cell mass that will contribute to your polycythemia. As well as this hypoxia will be stimulating your hypoxia derived PDGF, platelet derived growth factors, which will stimulate the growth of the distal ends of the fingers, contribute to your clubbing. So now let's focus only on the cardiovascular examination. Okay, starting from the inspection, palpation, percussion and auscultation. So all these three will be focusing in detail. Yeah. In inspection of cardiovascular system, the 10 basic points which you should look for is the shape of the chest. In seeing the chest, you can see the shape, and then the position of trachea, whether it's central or whether it's shifted to left or right. Then you can comment upon any distended vessels and the precordial bulge. How is the precordium? Whether it's any bulging is there or not. Then how is the apical impulse? Then look for each areas like pulmonary aortic areas like second left in the second intercostal space and right second intercostal space, and look for the parasternal area, left parasternal area. Then you can look for any epigastric pulsations, suprasternal pulsations, supraclavicular pulsations. Okay, and then any scars and sinuses there on the or not in the chest. Okay, so these are the 10 points to be looked out for. Yeah, so now we are going to see the patient. First, the chest wall shape appears to be normal as well as symmetrical, and any precordial bulge we are going to see. How to look for a precordial bulge in a patient is first ask the patient to lie in supine posture, then stand at the foot end of the patient and visualize for any precordial bulge. Okay, if you see in this picture, you can clearly see bulge is there in the precordium. So next question comes, when can you see a precordial bulge in a patient? It can be due to cardiovascular cause or can be due to also non-cardiovascular causes also. So if it is cardiovascular, next thing should be, we should see whether the ribs are involved or not. In this patient, if you see, you can easily observe the bulge is there and the ribs are also getting involved in this bulge. So if both are involved means, as we know, costochondral calcifications, the junctions get calcified by 16 years of age. So if any pathology is there in the heart before ossification of this area, then this will produce precordial bulge. So any congenital cardiac disease causing right ventricular dilatation, because right ventricle is just beneath this area. Right ventricular dilatation will expand this cartilage as well as the rib. So this will produce the precordial bulge here. If the ribs are not involved, only intercostal spaces are getting bulged. That can happen in pericardial effusions, where fluid accumulates around the heart and lifts off the intercostal spaces. It can't lift off the ribs. Yes. Next is other non-cardiovascular causes you should be knowing. So the first thing is mediastinal growths. Cancer of lung, like bronchogenic carcinomas of lung, which push the right ventricle, and the right ventricle causes bulging of the precordium. Okay, so all these are precordial bulge causes: cardiovascular, non-cardiovascular, ribs involved or not, and non-cardiovascular causes. Yeah, so now observe the precordial bulge for a minute. The procedure. Yeah. Next is, let's see how to look for an apical impulse. So for this, what are the steps you should follow? You can see in that video. First, you should stand in the right side of the patient. Next, first palpate the apex of the apex with the palm of your right hand. Then you will appreciate the heartbeat. You will appreciate the apex beat. After appreciating it, you can further localize by pointing your index finger. Some recommend changing it to ulnar side of the palm, then pointing it with the finger. Some books also recommend directly pointing out the finger. So this is apex palpation, apical impulse palpation. So in this patient, what happened was the apical impulse was in the fifth intercostal space, 1 centimeter medial to the mid-clavicular line. So this is the normal position of the apical impulse. Okay, so any apical impulse, how you should describe? First point is its location. How much extent is it involving? And what is the duration of the apical impulse in relation to the systole? So how to tell all these parameters? Location, as we know, after palpating, you will be easily localizing the intercostal space. And extent is nothing but like number of intercostal spaces involved. Okay, number of intercostal spaces, how much intercostal space is it involving? And some also tell the size of the apical impulse also, like normally it is 1 centimeter, how much it is enlarged, I say. Then the duration of the apical impulse. Duration, if you see, if it is in this patient, it was less than 50% of the systole. The duration of systole, how to assess? Just palpate the carotids. Okay, if your apex beat is felt throughout the carotids, like throughout the carotids beats, if you are feeling the apex beat, that means it is involving more than 50% of the systole. Here normally it will be less than 50%. So here it was less than 50% of systole. And also if you see the apex was and we were experiencing a lateral retraction. The palm, when you keep the palm, the lateral retraction was seen. It was pushing our hand to the lateral side. What is a right ventricular apex? Right ventricular apex, meaning apex is always formed by the left ventricle. But in some cases where right ventricle undergoes extreme hypertrophy, and this, if it forms the apex, then it is RV apex. What are the characteristic features that will tell it is the RV apex and it's not the left ventricle which has formed the apex? 3 points you should know. One is, how is the apex localized? RV apex are poorly localizable because RV is right ventricle, left ventricle. Just compare the muscle mass. Always left ventricle muscle mass is 3 times that of right ventricle. So you can easily feel the apex in some or the other intercostal space in case of if it is apex is formed by left ventricle. If it is formed by right ventricle, which is formed of a thin muscle mass, even though if it undergoes hypertrophy, it can't contribute to that palpable apex beat. So that contributes to a poorly localizing apex in RV apex. And there will be a lateral retraction which will be seen in RV apex, and there will be a medial retraction in seen in LV apex. Normally if you see in heart, what happens is early systole, the heart undergoes anti-clockwise rotation. So if you see there is a right ventricular hypertrophy, if the apex is formed by the right ventricle as shown in the picture, if heart rotates anti-clockwise in this heart, what will happen? This will push the impulse towards the laterally, that forms the lateral retraction. And if you see in those hearts where there is LVH, LV dilatation or normal apex, what happens is the heart undergoes anti-clockwise rotation. So this heart will go medially. There will be a medial retraction seen here. Okay. So yes, so lateral retraction for RV apex and medial retraction for LV apex. If you see the main thing, parasternal heave. How to appreciate this? See, stand in the right side of the patient and place your heel of the hand with your wrist cocked up. Okay, and feel for the heave. Try obliterating the impulse and see. Okay, so and also you should observe whether this heave appears in systole or in diastole. So these are basic steps you should see. Stand in the right side, place your hand with the wrist cocked up and experience the parasternal heave. Then ask the patient to hold breath if needed, and then see whether it's happening in the systole or in the diastole, and then try obliterating the impulse and see whether it can be obliterable or not. The Ames grading for parasternal heave is grade 1, 2, 3. First 3 things you should see: visibility, palpability, obliterability. Visibility. Only it is visible, but it is not at all palpable, then it's grade 1. It's visible, palpable, and it can be easily obliterable, then it's grade 2. It's visible, palpable, it's not at all obliterable, then it's grade 3. Okay, yeah. So next, if you see the epigastric pulsations. So for this, what you should do is stand in the right side of the patient, place your index finger in the epigastric region, apply a gentle pressure down and up so that you hit the tip of the right ventricle. Okay, so if the and also you should ask the patient to take a deep breath at this time. If you feel a impulse touching your tip of the finger, then it is due to right ventricular hypertrophy. If you feel the pulp of the finger, some pulsation is there, then it is due to aortic aneurysms. If you feel the pulsation touching the sides of the finger, then it can be due to hepatic pulsations. Okay, yes. So next are the normal pulsations, where and all you should see. Pulsations you can see for the aortic area, pulmonary area, supraclavicular pulsations you see, and in the neck as well as in the base of the heart. No pulsations were seen in this patient. Then thrills. For thrills, you should feel with this part of the hand. Okay, head of the metacarpals should be placed in each of the area, aortic, pulmonary, every areas. Okay, So there, if you feel, actually we had a thrill in the pulmonary area for this patient. Okay, and also in the left parasternal area also we had a thrill for this patient. So this is nothing but due to the pulmonary stenosis happening here, the subvalvular pulmonary stenosis which is happening here, contributing to this pulmonary thrill, as well as the VSD which is contributing to left parasternal area thrills. Yeah, coming on to auscultation. So first let me explain the normal path. First, actually what happens is the atrioventricular valves, tricuspid and mitral valves close, producing the first heart sound S1, followed by an isovolumetric contraction phase where all the four valves will be closed and the ventricles will be contracting to increase the pressures, and followed by, at one point of time, these pressures will exceed the aortic as well as pulmonary valve pressures. This will contribute to rapid ejection phase where the aortic and pulmonary valves open. So if there is any stenosis, at this point of time your murmur will start to appear. So only we tell ejection systolic murmurs are heard in the after some time after S1. It's not immediately after S1. Okay, so in the pulmonary area we can hear an ejection systolic murmur. Yeah, then after followed by S2. S2 means closure of aortic and pulmonary valves. But here if you see, since there is subvalvular stenosis is there, closure of valve doesn't produce any sound. Only aortic valve closure will produce sound. So that contribute to single S2. One more finding, single S2, which is nothing but A2, which will be heard in the aortic area. Followed by, what happens is your diastole will be normal and it will be followed by another S1. One lot to be noted into. First, S1 here was present. S2, there was only a single S2. There was no S3 or S4. Then, if you see, P2 was absent. Only A2 was present. That contributed to single S2. Then, any murmur, when I am going to tell, should describe all the parameters of the murmur. First is the timing of the murmur. How is the timing? Whether it's during systole or whether it's during diastole. How to identify this? Simple technique. Just palpate the carotids simultaneously. If your murmur appears during the beat, carotid beat, upstroke, then that means it's a systolic murmur. If it happens in the opposite way, then it's diastolic murmur. That's all. Then the grade of the murmur. Here, since it was associated with thrill, definitely the grade will be more than 3. It was 4 in our case. Then the quality of the murmur, whether it's harsh or soft. Then it was an ejection systolic murmur. Then any conduction radiation? No. No conduction, no radiation. Then it is best heard with the diaphragm. The pulmonary stenotic murmurs best heard with the diaphragm. Next, pitch was high pitched and location is in the left second intercostal space, which is nothing but the pulmonary area. And this murmur increased with inspiration. This is very important. This is Carvalho sign. It should be done. Yeah. So these are the points describing the murmur, pulmonary stenosis murmur in tetralogy of Fallot. So, and also it should be followed by examination of other systems, respiratory, CNS, as well as per abdomen. Final will be your diagnosis rating. So here it can be written as congenital or acquired. It's nothing but congenital. It's cyanotic or acyanotic. It's cyanotic heart disease with a right to left shunt, obviously. With pulmonary stenosis, probably tetralogy of Fallot, patient not in atrial fibrillation or not in failures or not in without any signs of infective endocarditis. Okay, so all these things you should be incorporated in your diagnosis. Yes, hope you liked this kind of clinical demonstration videos. We'll be doing regularly each system by system. The PDFs of these videos will be uploaded in our WhatsApp and Telegram groups. Do follow the channel for further videos like this. Thank you.